Thank you all for joining this webinar today and taking time out of your day to join. Just wanted to chat about kind of an important issue for Men's Health Month, and seemed fitting to do it around this time of year because it's an under-addressed topic in men's health is stress urinary incontinence. And we'll kind of get to the bottom of what all that means and what that involves, and that's kind of what the purpose of this webinar is. Just wanted to tell you a little bit about myself before we get started. And so I'm a urologist here in Denver. We have offices that are based out of Lone Tree and Littleton. They're about 15 minutes apart. And, I'm originally from the Midwest, but really happy to be in Denver. I grew up in Chicago, went to the University of Illinois in Chicago, did my medical training at Ohio State University, and then did my residency in the outskirts of Detroit at Royal Oak at William Belmont University Hospital, where I got training in some of those kind of topics that you see below and what Brenda alluded to. As part of my training, one of the things that I really focused on was survivorship for prostate cancer. And I think she mentioned that. But what a lot of the major lifestyle issues that happen after your cancer is cured are lifestyle issues. And those usually involve erectile dysfunction and incontinence, so leaking urine. Those are the two primary functional outcomes that don't always get addressed after the cancer is treated. And so I think it's an underserved population. I wanted to talk specifically about stress urinary incontinence today, so leaking urine. And so male stress urinary incontinence is basically leaking that happens when you apply pressure to the bladder of some sort. That pressure can come in different forms, but often happens when you're physically active, lifting weights, coughing, laughing, sneezing, running, those kinds of situations. And when you think about the prevalence of this, it affects about 17,000 new men annually in the US. And so it's a pretty large population, and often one that's generally underserved. So this is kind of a diagram that points out what the urinary system looks like. And if you kind of visit me in clinic, it's one of my favorite things is to kind of point this out so that you have an understanding anatomically of what's going on in your body, because once you understand that, it's relatively simple. And I think of myself as a glorified plumber. And so if I can show you the plumbing, it makes it quite a bit easier to explain what's happening. So here you kind of have a couple of different parts of the body. So you have the urinary bladder that's up top. That's what stores the urine. It sits right behind the pubic bone. Below that, you have a muscle that you can't really see in this diagram, but right between the prostate and the bladder, there's something called the internal urinary sphincter. It controls your ability to maintain continence and is often sacrificed in surgeries such as resection of the prostate, like a transurethral resection, or a prostatectomy for prostate cancer. But that's okay, because usually you have another sphincter below that's kind of pointed out there below the prostate that we leave intact with the hope that you actually are able to use that to control your leaking. And so with one of those sphincters, people maintain their continence. But when both are negatively affected, which sometimes happens in surgeries like a prostatectomy for prostate cancer, people tend to leak urine because there's no stop gap at that point in time. When you try to urinate normally, these sphincters relax and allow that urine to flow. But when they're negatively affected, that's when people leak. So a couple of things that we like to talk about is that there are causes and comorbidities associated with stress urinary incontinence. And I kind of referred to some of these or alluded to them previously, but sometimes BPH surgery can cause stress urinary incontinence. It's relatively rare with the visualization that we have for most of our endoscopic procedures for BPH, meaning no incision surgery for enlarged prostates, because we can actually visualize the location of that external sphincter. So while we do take the internal sphincter as part of that prostate surgery, we leave the external sphincter intact. So it's relatively rare cause, but that is one. Sometimes neurogenic conditions of any sort, neurologic conditions can cause it when you don't have that mind-body connection, and the sphincters are acting in a different way than we're designed to do. So relaxing when you don't want them to, or contracting them when you don't. Those are things that can kind of cause urinary dysfunction. Pelvic surgery of any sort can cause it, and that includes colonic surgery for rectal cancer, urethral and prostate surgery as well for prostate cancer. And so those are the most common causes why men experience stress urinary incontinence. So it's a little bit of a different cause than why sometimes women experience incontinence. Um, Urinary incontinence has been shown to affect quality of life. It can, it's bigger than just leaking urine. It can be associated with depression. And while I think a lot of men are familiar with erectile dysfunction, especially after something like prostate cancer surgery, leaking urine is not something that they hear about as often. And so there's not as much commiserating around the water hole, if you will, about the incontinence. It's often something that people kind of keep to themselves. And sometimes that can negatively affect quality of life too, just not being able to talk about this as a problem. And that's one of the reasons why I wanted to talk about this for Men's Health Month. Other kind of lifestyle issues that can happen around leaking urine is, it can cause skin irritation in the area where you're leaking urine. It can lead to rashes and sometimes even fungal infections, especially in people who are diabetic. And then oftentimes if somebody is less mobile, often in a wheelchair or laying back flat, it can cause wound healing issues that people develop as ulcers form in pressure point areas. So I kind of alluded to this a little bit recently, but stress urinary incontinence and prostate cancer treatment kind of go hand in hand. It's one of the more common things that we talk about in our counseling for prostate cancer treatment, specifically surgical resection of the prostate or robotic laparoscopic prostatectomy. And in the US, about 90,000 radical prostatectomies are done each year. And if you kind of take all comers at about a year out, so that's 12 months out, 1 in 10 men still do not have return to continence. So if you see me in clinic and, we talk about prostate cancer, one of the things that I quote as a percentage is that about 75 to 80% of men at about the 3-month mark have urology dry at about 3 months. Another 5 to 10% of people regain continence at about the 9 to 12-month mark. And so when you look at that, about 10% of people, so 1 in 10 people, continue to leak even after a year. And after a year, if you haven't regained continence, the likelihood of you doing it spontaneously or even with pelvic floor physical therapy is relatively low. And so that's worth knowing as well, that at about a year out after prostate cancer surgery, the chances of that returning on its own is unlikely. And that's really when we start to talk about more involved treatment options other than kind of your basic ones. So just to kind of reiterate, this is kind of the diagram that shows exactly which parts of the body we're affecting when we do a prostatectomy. So because this is done for prostate cancer, we don't leave the capsule of the prostate behind. We take the whole thing to make sure we get a good margin on the cancer. And as a result, you can see that the area that's circled where the excision is done involves both of the sphincters to a certain degree. And so when you reconnect the bladder and the urethra, there's actually less of a sphincter mechanism present. And if anything, the only sphincter mechanism that's left over is the external sphincter. And that can affect the ability to not leak urine. So when we go over stress urinary incontinence treatment options, it comes in a variety of forms. And just with any patient that's being treated for any condition, you want to start with low-hanging fruit, less invasive options first. And so a couple of things that people talk about are behavioral changes. So drinking less fluid, which is of course harder to do in the Denver area, considering how dry it is and need to stay hydrated, especially when most of the patients that I have here are super active. Having more planned restroom breaks, so not allowing your bladder to get too full before you're trying to empty. And so we do know that stress urinary incontinence is worse when there's more volume in the bladder. Then you have kind of a step up from there, which is some sort of intervention that usually involves pelvic floor physical therapy, which is basically, in a very layman's terms, Kegel exercises. But the pelvic floor physical therapists kind of focus on a whole body approach and give you techniques to help with urinary incontinence. And they really do a good job of something called biofeedback, which is creating a mind-body connection to help you control the incontinence. And I would say that for the most part, pelvic floor physical therapy after surgery, let's say that's BPH surgery or for prostate cancer, um, is most effective in the first 3 months. It also provides an earlier return to continence. So, whereas we talk about slow return to continence over a year for men who've had their prostate removed for prostate cancer, that can be accelerated with the assistance of pelvic floor physical therapy. And that's a good tool to have in our toolkit. And then obviously, while you're leaking, there are coping mechanisms, and those involve pads and diapers, which I'm sure is not surprising to the viewers on this webinar. We also have the ability to place a catheter that can drain the urine and reduce leaking, although I can't say most patients are happy with that as a lifelong solution. And then one of the things that we do talk about when you come and see me for these issues is penile clamps. So it's also called a Cunningham clamp. They're available on Amazon, and they're an external device that can be placed around the penis and provide a clamp that prevents you from being able to urinate. I would say the biggest issue with that people experience sometimes with those is sometimes skin-related breakdown from having them on too long, or potentially discomfort from the clamp itself. But it is an option that some people opt for that's less invasive. As you start to talk about surgical options for incontinence, I usually start to talk to people about this when pelvic floor physical therapy hasn't worked. They're not interested in a Cunningham clamp, and it's been at least 9 to 12 months since they've had their prostate removed for prostate cancer, is when we start to talk about these other options. And so generally, there are two major kind of products that I'd like to talk about. So one is called the Male Advanced XP Sling. This is designed to treat mild to moderate stress urinary incontinence. And how do we define mild to moderate? Well, that's a little bit of a challenging question to answer. Sometimes, depending on what you look at, that's based on the weight of the pad that you're having when you leak. But the last time I checked, there's no scale that we have to weigh these pads. And so what we use is kind of a qualitative assessment rather than a quantitative one to assess mild to moderate. And so usually less than 3 to 4 pads per day is considered mild to moderate stress urinary incontinence. And the sling system is a little bit of a less invasive surgical treatment option. It's not for everyone though, and I wouldn't necessarily recommend it for anybody who's had pelvic radiation therapy. It works on its own to restore continence, meaning that there is no mechanical device that's activated to provide continence or prevent leaking. It works in the background. There is no user intervention required, meaning that there's nothing for the patient themselves to operate. And it can reduce reduction in pads that are needed to be used by a person by up to 77%. It's important to remember that with any of these options, when we talk about dry, we're talking about urology dry. Urology dry is not bone dry. Urology dry is usually 0 to 1 pad a day. And I would say most of my patients who are leaking a significant amount, 0 to 1 pad per day would be actually a huge success. That would allow them to be active again, to participate in the activities that they're really interested in. Like had a patient recently who was back to golfing, and those are nice metrics to have. And so 0 to 1 pad a day in our mind is a success, and that's the goal for most of the things that we talk about here. The mechanism of the advanced XP sling system is one that is a hammock. And so that's the best way to describe it. So it's not compressing the urethra. It sits as a hammock beneath the urethra, and it's anchored around the pubic bones on either side. The incision that we make to place the sling is behind the scrotum and in front of the rectum. So it's a incision that's made in an area called the perineum. And through that, we're able to place the male XP sling, and it, similar to female slings, actually provides a nice cushion or support underneath the urethra. And we're not compressing the urethra. And so a natural question is, how does it help me prevent me from leaking if it's not compressing the urethra? And so what I like to explain to people is this concept of dynamic kinking. This is how slings work in both men and women. And so what happens is that let's say this is the bladder here, you have your urethra here. The sling just sits below the urethra and provides support. And so when you cough, sneeze, or active, the bladder drops some. This area right here kinks, and the kinking is what prevents people from leaking urine. And so it's a pretty effective treatment. The reason why we try not to make it too tight is because if we compress the urethra, it can cause a different set of issues in men. Men with enlarged prostates maybe can attest to this, is that it prevents you from urinating and can cause a blockage of the system. And so the goal is to just provide it as a hammock to support the position of the urethra as opposed to compressing it. And so when you look at the data, about 88% of people who've had this procedure done recommended it to a friend. The second treatment option that we talk about is the AMS 800 artificial urinary sphincter. So artificial urinary sphincters, often considered the gold standard for treatment of male stress urinary incontinence, are designed to help treat really any incontinence, but more specifically are available to people who have even moderate to severe symptoms. So it can be placed even in the setting of a prior history of pelvic radiation, although there are some things to be considered when somebody's had radiation in the past, and that's something that we can kind of talk about later. It's designed to be discreet, so none of the device is physically visible. It's all internal. And to the untrained eye, there would be no evidence that this device was in place. It basically mimics the function of a natural sphincter. So it actually sits as a cuff around the urethra and has basically acts as a balloon that inflates and puts pressure around the urethra to prevent you from leaking. And so at its rest, it's in its active state. And to be able to urinate, you have to actually activate the device manually with your hand to be able to push the fluid out of the cuff and allow the urine to kind of flow through. And then automatically it restores your continence by reinflating. And so I have a video that demonstrates it because it's a little bit of a difficult concept to explain verbally. So I'll kind of show you here in a second. One thing to keep in mind is that if this is a procedure that you opt for, it's really important to have a couple of things that we check on. And one is the cognitive ability to utilize the device. Meaning that you have to be able to kind of think that, hey, I need to urinate and be able to get to a restroom and activate the device. And you also have to have the manual dexterity to squeeze the pump to be able to activate the device. So those are a couple of the things that we check on before we ever talk about doing the surgery. And before we actually operate, we always do something called cystoscopy, which is where we take a camera and look inside the bladder to make sure that the entire channel is open. Because sometimes the place where the bladder and the urethra get connected after prostate cancer surgery can narrow. If it's narrowed, it's important to treat that narrowing before placing this device in someone. And so those are a couple of the safety metrics that we always keep in mind before talking about doing an AUS. This is the video that I wanted to kind of show you. It kind of demonstrates briefly how the cuff gets activated and where different parts of the system sit, because it's actually a three-piece system. And the pieces include obviously the cuff that sits around the urethra that you can see there in yellow in the back. There's the pump in the scrotum that almost acts like a third testicle that actually is used to activate the device. And then you need a place for the fluid to go when it's not in the cuff when you're trying to urinate. And that sits right above the pubic bone. So there's three parts to that system. And so as you squeeze the button that's in the scrotum, the fluid flows from the cuff into the reservoir that sits above the pubic bone. And then the fluid flows back automatically to regain continence. And so that's the device in a nutshell. When you think about long-term expectations, the big thing to know is that it's usually done as an outpatient or just a single day overnight procedure. The procedure is done with two small incisions, one behind the scrotum, similar to the sling that we talked about, and another one above the pubic bone. It takes a few days to return to non-strenuous activity, so people do take it easy for a couple of days, and then non-strenuous activity for a couple of weeks after the procedure. And then immediately after the placement of the AUS sphincter, we wait about 6 weeks before activating it. So we want everything to heal before we start activating it. So sometimes people are surprised to hear that after the procedure, they still leak for 6 weeks before we're actually activating that device. Usually the goal after device activation is bringing you to, again, urology dry, less than 1 pad a day. And so if you kind of look at survey results based on other people who've had this procedure done, satisfaction rates range over 90+%. And that lasts for about the 5-year mark when you kind of reassess people, obviously immediately after, but then even 5 years after the procedure is done, most people are happy that they got a procedure like this done. The couple of things that I think people think about with any kind of medical procedure is what insurance coverage looks like. And it's important to know that both the sling system and the artificial urinary sphincter are both covered by Medicare and private insurances when deemed medically necessary. And that's a conversation that we have always with the billing department. So I always like to get our billing department involved to basically run numbers for patients so that they can understand what to expect, because just as important as any kind of medical toxicity is financial toxicity, and keeping that in mind is really important. And then because coverage varies between different insurances and different locations based on where we do the procedure, we will definitely kind of try to work with the billing department to give you a better estimate on what that looks like. What are the advantages, obviously, to treating incontinence? Obviously, regain bladder control, being able to urinate when you want and do the activities that you want without worrying about leaking, and having to change out pads, especially in public places. The implants that we're talking about here from a surgical treatment standpoint are all undetectable and inside the body. Patient satisfaction is high. From a skin care and skin breakdown issue, it can be a huge advantage. And it can provide people with confidence that they have otherwise lost after prior procedure. There are possible risks involved with any type of surgery, whether that's sling or the AUS. And so when you think about risks of male slings, a couple of things that we think about are device failure, so the chance that the sling doesn't work. Obviously it's designed for a patient that has mild to moderate symptoms. And so I try to reserve that for those group of patients. That rate of failure is higher if you try to push the limits to somebody who has more severe incontinence. So that's something that it's a discussion that I have with patient about who's the right candidate for this procedure. But when you pick the right candidate, somebody who hasn't had radiation before and who has mild symptoms, usually patients are really happy. And so patient selection is really of utmost importance in that situation. If you make the sling too tight, theoretically, people can have urinary retention, meaning not being able to empty your bladder. And that's something that I spend a lot of time on intraoperatively to make sure that doesn't happen, because that is a key of the procedures, to make sure that it's just supportive and not compressive, like we talked about before. Some people have postoperative pain, especially in the medial part of their thigh or at the incision site that we make behind the scrotum. And then theoretically irritation at the womb site, but that's kind of true for any surgery. The risks of an AUS include, because there's a more mechanical device at play, you can have device malfunction or failure that sometimes requires revision surgery, although the timeline on that is usually 7 to 10 years, depending on what literature you look at. The other thing that we think about is erosion of the cuff onto the urethra, because the cuff is providing support around the urethra. And so if it's applying too much pressure over long periods of time, sometimes people can have the actual cuff erode into the urethra. And that's something that sometimes requires revision or replacement of the device and urethral repair. Urinary retention is theoretically a possibility, although that's quite rare after an AUS. And may require temporary catheterization. There's obviously infection of the device, pain and soreness, although I don't think any of those are necessarily unique to this. One of the things that I do try to make sure of before placing a device like an AUS in a patient that's supposed to be indwelling for a long period of time is that the patient's diabetes is under well control. Is well controlled, and so I always talk to patients about making sure their hemoglobin A1C is being checked, and if it is, making sure that that's within a reasonable range. And then obviously, if over time, as people get older, they lose some of their physical or cognitive ability to operate the device, that's an indication to deactivate the AUS. And so we can lock that in an open position, and it doesn't always necessarily need to be removed at that point in time, but would be a reason why we couldn't use it anymore once it was placed. And so, this is kind of a nice summary page, and there's a web URL here that you could probably learn a little bit more at. Obviously, you're more than welcome to schedule a consultation with me, and we can talk about your specific situations and kind of come up with a plan that makes the most sense for you. But the URL here is fixincontinence.com. And if you'd like to get more information, you can always go there. There's also a QR code here that if you wanted to access, that'd be perfect. And then I just wanted to leave my name here, our office, and the phone number in case you had further questions and wanted to schedule a consultation. But at this point in time, I'd like to kind of open it up to the floor and see if there's any questions. I'll try to keep it a little bit more high level rather than patient specific questions, so that we can try to make sure that we're reaching as many people as possible, and making sure that as many people as possible can get their questions answered.
Thank you, Dr. Shah. We do have a few questions that have come through the chat. The first question is, what procedure is done for an enlarged prostate? I have problems with draining.
Yeah, so prostate enlargement and having urinary symptoms secondary to that often involves doing a little bit of a workup that usually involves an exam to make sure that we understand the size of the prostate. Usually the easiest way to do that is a rectal exam that's done digitally, but you can also do an ultrasound to assess the size of the prostate. And then what we also talk about is doing a scope inside the bladder, the cystoscopy that I mentioned earlier, where we have a catheter with a camera on the end that we take into the bladder to evaluate the shape of the prostate. So between knowing the shape and size of your prostate, we can come up with a surgical plan for an enlarged prostate. Those can range from anywhere from minimally invasive endoscopic procedure all the way to a robotic procedure to help with your symptoms. And so that's kind of the general management for enlarged prostate.
Thank you for that. Next question. With an artificial sphincter, do you feel like you have to urinate at some point?
Yeah, so in general, as long as the bladder is healthy, people should get the sensation that they need to urinate. It's a rare person whose bladder over long periods of time is so enlarged and decompensated that they may not get the sensation to urinate. But it's a rare person, especially someone who leaks urine. It's rare that I have a person who gets an AUS and doesn't get the sensation that they have to urinate. Most of those people actually, prior to them starting to leak, were getting the sensation. It's just that some kind of procedure or event actually made them leak. And so the bladder should be healthy. In certain situations where the prostate has been enlarged for long periods of time, what happens is that prostate blocks the flow of urine, and over time the bladder starts to accommodate more and more fluid. And as it starts to do that, it gets so dilated to a point where people lose the sensation that they're full. And so that person may not have that sensation, but the AUS itself shouldn't prevent you from having the sensation that your bladder is full and that you have to go. So the body gives the warning to you that, hey, it's time to go, and then you have to go to the restroom and activate the sphincter to be able to urinate.
Thank you, Dr. Shah. Next question. With this implant, will I be able to stop traveling with a suitcase full of pads?
Yeah, I mean that's the goal, and you wouldn't be unique in asking that question. That travel plans, being active, always having to kind of plan around bathrooms, being able to plan around the pads that you're using can be a really frustrating thing. And the whole goal of this is to improve quality of life by addressing those issues, and so that you're not necessarily walking around with a suitcase full of pads. That's the whole goal for sure.
Next question. You mentioned neurogenic conditions as a cause. Has physical therapy shown positive efficacy with this diagnosis?
Yeah, that's a little bit of a mixed bag. And so that's always a difficult patient population to treat. The way that I like to think about physical therapy is that really anybody can benefit from physical therapy. Um, and when you realize that, I think that really opens the door to kind of sending more people their way. And I think that they love seeing people with a variety of different conditions, because what I hear from the physical therapist is that they have something and some role that they can play in helping voiding dysfunction, can help some of the neurologic conditions, can even help provide techniques and cues to help people who are having symptoms related to the neurogenic conditions. Now, when I say mixed bag, I mean that not all of the problems are going to be fixed with physical therapy if there's a neurologic cause, but certainly they can provide techniques and tools that can be helpful for almost anyone.
Next question. If I'm already using just one pad per day, is the sling worth considering?
Yeah, that's a great question. Actually had just a patient today that was asking a very similar question, and so the sling procedure is a an option for even one pad a day. At some point, the most important thing to ask yourself is how bothered are you? Would you be happier getting down to maybe 0 pads a day if you're leaking a very small amount? For some people, that's weighing the kind of risks and benefits of surgery, depending on what your personal situation is. But if you're healthy enough for surgery, I think that the biggest question that I usually have for patients is how bothered are you? Because none of what we're talking about here is life threatening. It's more so designed for quality of life, which is maybe just as important. But when we talk about doing a procedure, it's really worth asking yourself, like, will this affect my quality of life? Will it help? And if you're happy at 1 pad a day, which a lot of my patients are, maybe it's not worth it. But if you say that, hey, this is really bothering me, and I would really love to maybe potentially do something that's relatively less invasive with good outcomes, I think it's worth trying. And it's always worth remembering that with any of these procedures, if for whatever reason it's not working or you need it removed, it's not very involved to remove these devices if needed either. And so I think that those are all things worth keeping in mind.
Thank you, Dr. Shah. It looks like we have a couple questions left. How long after surgery do you start pelvic floor physical therapy?
Can you repeat that question? How long after surgery, you said?
Can you start pelvic floor physical
Yeah.
therapy?
Yeah, so this is kind of if you ask 10 different urologists, you'll get 10 different answers kind of question. And what I mean by that is that some people will have patients start pelvic floor physical therapy prior to surgery. Some people will start pelvic floor physical therapy immediately after surgery, and some people will wait a little bit. I'm of the opinion that sometimes the people who are getting surgery have a lot on their plate. There's a lot of things that they're thinking about, logistics, they're thinking about the actual surgery, there's nerves at play. And sometimes I feel like too much homework at that stage in the game can be a little bit counterproductive. It can overwhelm people. And so I'm of the opinion that I try to wait a little bit after surgery. And what's a little bit? Usually a couple of weeks to maybe up to a month after surgery to start pelvic floor physical therapy. Mostly because before surgery, there's the nervousness of the procedure. 2 weeks afterwards, there's the recovery period where you are still kind of getting over what you had done. And so I don't know if that's the best time to be doing physical therapy. At about 2 weeks to a month after surgery, I think most people are cognitively kind of at a place where they feel like that would be something that they would be have the energy and incentive to start. They're now kind of experiencing incontinence, so they have the motivation at that point in time. And so that's when I see people going to pelvic floor physical therapy most commonly. But realistically speaking, any time is a good time. I think that that's kind of my practice pattern. Depending on what you look at, the pelvic floor physical therapy data for stress urinary incontinence after surgery in men says that it doesn't increase your likelihood of regaining continence. It just accelerates your return to continence. What that means is that your chance of achieving the same result by doing nothing is about the same. It just might take longer. And so when we're talking about in the course of months versus up to a year, that may be the difference worth it to start physical therapy, but it's worth knowing that pelvic floor physical therapy has not been shown to increase overall rates of continence, just the rate to return of continence.
Thank you, Dr. Shah. We've got a couple more questions that have come through. This is a two-part question. I take heart medications. Will I still be able to have the surgery? Do I need to see my cardiologist about discontinuing the medication? And can you speak a little bit on how reliable this is? Has it been available for a long time?
Yeah, so absolutely. If you are on cardiac meds and see a cardiologist, I'll routinely have patients who are in that situation clinically see their cardiologist, see their primary care, make sure their hemoglobin A1C is okay, make sure that their heart is healthy enough to undergo surgery, which usually involves an EKG and an echocardiogram, depending on the patient, and some basic blood work. And once the cardiologist feels okay that, hey, you're healthy enough to undergo surgery, that's when we start undertaking the scheduling process. We also try to make sure that we coordinate with the cardiologist specifically in terms of medication management, because not all medications from a cardiac standpoint need to be stopped. Usually blood thinners do for a small period of time before and a small period of time afterwards. But all the decisions in terms of when to stop, how long to stop, what medications to stop is all patient driven. And so that's a very personalized decision that we make as a joint kind of a group, the patient, the cardiologist, and myself. And then I think the other question was, how long have these procedures been around? It's been around for many, many years. And so they are not new devices, and they have a proven track record, although the quality of the devices has improved over time. They're not new devices. And so the quality of the device may affect the long-term, reliability of the device, but shouldn't have any effect on your experience as a patient. There's more and more research and development going into this constantly. So yeah, no, very proven track record.
So the final question, is it possible to speak with someone who has had the surgery?
Yeah. So I guess that's a good question. Maybe I'll leave that open to you guys. I think that like trying to get you coordinated, with somebody who's had the surgery. Sometimes there's like support groups that we can network you with. And I don't have anything listed off the top of my head, but that should be very possible. Obviously, in this process, we want to be very cognizant of not violating any of the patient privacy type of issues. But usually people who are in support groups, specifically prostate cancer survivorship groups, are excellent resources because they are there to kind of provide their knowledge and intelligence to this issue. So any prostate cancer support group will be, I'm sure, full of people who've had procedures like this done.
Thank you, Dr. Shah. And we do have a list of patient champions who are trained to speak about their experience. If anybody is interested, please send me an email and I'd be happy to put you in contact with somebody that you can speak with one-on-one. Dr. Shah,
So
looks like those are all of the questions I am seeing right now. Oh, I have one more. Will Parkinson's have a negative impact on this? It sounds like it's a potential patient with Parkinson's who's interested in the procedure.
Yeah, so Parkinson's is a little bit more of an involved disease process that can affect many different parts of the urinary tract. And so more information is necessary before treating Parkinson's. The most important thing is to not do the wrong procedure for the wrong person in with that situation. And so a couple of things would play into that, right? So one would be how well controlled is the Parkinson's right now from a physical ability standpoint. So for example, if you were considering an AUS placement for leaking, it's really important to be able to actually manually squeeze the pump. Is that something that the person could do? So that's one question. The other questions that kind of come up is like the actual clinical side, and that's where I kind of jump in, is to understand what's happening when the person leaks, because leaking can involve a couple of different sources. It could be the bladder that's squeezing when it's not supposed to. It could be the sphincter that's not relaxing when it's not supposed to, or maybe the sphincter's not relaxing and the bladder's getting too full. And so there's a number of different types of incontinence. And for Parkinson's specifically, I would always want to do something called a CMG test before recommending any type of surgical intervention, which is where we place a catheter into the bladder, a catheter in the rectum, and we fill your bladder slowly with fluid in order to see what happens when we fill the bladder with fluid and what happens to pressures in the bladder and the urethra when you try to urinate. And so it provides us a really nice qualitative assessment of what is happening when that person is urinating, so that we understand where the problem lies before offering surgery. And so that's essential when you're talking about a neurologic disease like that.
Thank you, Dr. Shah. Dr. Shah, thank you for your time in giving the presentation this evening. To all of the participants, thank you for joining us tonight. We appreciate all of your questions. We hope that the webinar has provided some insight on treatment options for these disease states and about solutions that can help restore dignity in your quality of life. Dr. Shah, I'm going to kick it back to you for any final closing comments.
Yeah, so thank you guys all so much for joining. I was happy to have you and kind of addressing this under talked about issue for Men's Health Month. It was my pleasure kind of presenting to you guys. I think that a lot of the questions that come up with treatment options often involve like a patient-centered approach. And so what's a priority to the patient? What are their health factors? History factors factor into a lot of the decisions that we make. And so oftentimes what I find is the most productive thing to do is to sit down and have a one-on-one conversation about what it is that's going on, so that we can kind of come up with a treatment plan that best fits you. And I'm happy to see you anytime. And so you have our number for our clinic there, and we're always pretty open to scheduling appointments in an expedient manner. So I really appreciate you guys joining, and I hope you have a good rest of your night.
Thank you, everyone. Have a wonderful evening.
Take care. Bye-bye.